Good afternoon, everybody, and welcome to, what we got, just one more day of the forum? I always like to say that as a joke because it's Friday afternoon, everyone's tired. No, this really is the last day. So welcome to the afternoon of the forum and a session on thinking about how to understand how safe your hospital is through defects and understanding some diagnostic tools. So I'm Carol Haraden. I'm a vice president at the Institute for Healthcare Improvement, and I am joined by two wonderful colleagues. Roger, you want to quickly stand up and say who you are? I could do that too.
Yeah, you can do that.
Okay, so Roger Resar. He's a pulmonologist and critical care doc. Has worked and still does work in the Mayo system, but been a faculty member and a fellow at IHI for as long as I've been there, 15 years. And also joining with us is Kathy Luther, who's a vice president looking at care in North America and also in hospitals. Leads all our hospital cost and quality work, actually across the continuum. And also has been doing a lot of work with Roger on this defect analysis and has a background as long as your arm. If I stood up here and told you all the jobs she's had in healthcare, we'd be here a long time. So we've got tons of experience in working in healthcare up here with us today, so that's great. Slides? Is there a clicker? On the lectern. Okay, I should know that, shouldn't I? Okay. All right. No. That's the pointer. I will usually do that. Okay, so let's just review why we're here together. We want to look at some proven approaches to assessing safety in a hospital. We want to understand the limitations of any one approach to give us a sense of how safe we are and understand key safety problems that need to be addressed. So it's sort of like the airplane that says, this airplane is going to Boston. If you're not going to Boston, get off now. Okay? So this is where we're going. Okay. So, Roger.
Tim, you have me on?
Yep.
Great, thank you. I'm Roger Resar, and I'm pleased to be here today. We're going to present a concept, and that concept has to do with a trajectory that we've observed over the last decade as IHI teachers in terms of safety in the organizations that we've worked with. And coming out of this is an idea of a trajectory that as we've looked back at our work, organizations have fallen into this trajectory. So why not take advantage of that knowledge and share it with you? We're calling it calibrations. Now, a calibration is something that shows your position or value. And we think that there are two major calibrations that we've been working through in the last decade. And unfortunately, safety hasn't improved very much in our hospitals, in spite of the fact that we've been working diligently on these two calibrations. We are going to hypothesize today that there is a third calibration that we all need to do in terms of the trajectory for safety, and we're going to present that to you today, at least for your opinion and judgment. So calibration number one is the large project. The large project is noted by one major attribute, and that is it's a top-down project. It's something that leadership says we're going to do. Those of you who have worked on nosocomial infections, those of you who have worked on central line problems, those of you who have worked on narcotic overdoses, whatever it is, those tend to be very large projects, very top-down. It's a macro approach to safety. Now, this is necessary but not sufficient to actually move the burden of harm in your organization. So, we've had successes, we've had failures, but there's more that's needed. There's obvious more that's needed, and let's share that. That's the second calibration. The second calibration is looking at mortality. We looked at mortality over the years and have come up with various ways of studying mortality in an organization. Carol's going to spend some time on that. The scary part of it is that when you look at the first calibration, that is comparing your organization's infections with some other organization or with some leading body like a CDC or some other measurement mechanism, you can say you've had success or you've had failure. You also can look at mortality and you can say, death gives us a window, gives us an opportunity to look at the safety of an organization, and that's a good thing. You can compare your mortality to other organizations. That's a second calibration. The third calibration we're going to hypothesize is that we need to think about safety from the bottom up rather than the top down. And we are going to expose you to a methodology of actually surfacing very small defects. And that these very small defects are worked on by a team of two with minimal data collection using pencil and paper. The projects are finished in 1 month and very little training is needed to do it. It is almost the antithesis of the large program, the top-down program, which is calibration number 1. Now, why are we hypothesizing that we need a third calibration? Because with calibration 1, these very large top-down projects, we've had a lot of experience. We've had the 100,000 Lives campaign. We've had a lot of motivation. It's been successful. Some hospitals have gone years without a ventilator-associated pneumonia. However, we have studies now both in the U.S. using the Global Trigger tool in North Carolina and some Dutch studies that suggest in spite of these large projects that we're doing, we have not significantly improved safety in our hospitals. If that's the case, we have to ask why, because otherwise we're not going to get further along on the trajectory. What are we missing? Calibration number 2 is looking at mortality. Mortality says people die sometimes because it's the end of their journey in life, and other times they die because we did something that caused that. We have to try to find that out, and we've worked on mechanisms to do that. Carol?
Thanks, Roger. Okay, so the questions we want to ask ourselves when we have, would it be better if I stood up for the people in the back? Yeah, okay, thanks. Not used to, those lights are just horrible, that's why. Okay, so what we want to understand when we think about mortality is really, the first question we have is people have big mortality rates, but they don't tell us very much. Even if you have mortality rates from surgery or you say this many people die from community-acquired pneumonia, it looks as though when you have those rates that that's really the proximal cause of death. And when we get deeper into it, we find often the disease process is not the proximal cause of death. So it's actually not all that helpful to us. So I always say to people, what data do you have about how people are harmed? What data do you have about why people die? And is the death, as Roger says, the end of life journey, or did we go ahead and hurry that up for some people? So for a lot of us, we have all of these, we have tons of tools and tons of data all over the place. So mortality review, incident data, concurrent review, risk management, all of this. And the question is, how do you bring this together and say, what are the important and recurrent issues that are high volume and high impact that we can actually succeed with? So what we find is that needless death is beyond a single event onto a much more complex systems issue, and so do you. But looking at harm rates or looking at mortality rates do not give you that complexity. So how many of you have mortality and morbidity rounds at your organizations? How often is that just like straightforward? Well, this happened, they died, and on we go. It's always full of uncertainty. It's always full of worries and questions. So how do we think about complexity? So if you agree, do you agree that people die unnecessarily every day in our hospitals? If you don't, what follows will not be of interest to you. Okay. So we need to think about a diagnostic journey that helps us think about why that's happening. So how many of you use the 2x2 mortality analysis tool? Well, a few of you, not a lot. So here's what I'm going to talk to you about. So we think about a 2x2 matrix that's based on, and in the UK, we think about a 3x2, and I'll tell you why. Because in the United States and in many places, there's intensive care and non-intensive care. In the UK, we have sort of two forms of intensive care. We have the ITU, where patients are ventilated, and then we have what essentially, I guess, I would call a medical ICU, although surgical patients will go down there as well. But they're both two levels of intensive care, HDU, or high dependency. So we break that out. But the two criterion which you judge these events against are, was the patient admitted for palliative care? Not did that become that way over time. Were they primary diagnosis admitted for palliative care? Was the patient admitted to the ICU? Not sometime during the stay, but initially. So here's what it ends up looking like. So, and again, imagine if you're in the UK, you have a third box here as well, because you're thinking about ICU and HDU. So box 1, the patient was admitted for palliative care and admitted to the ICU. How many of you would have patients in that box? Who is here from the United States? Because if there is anyone here, you've got patients in that box. Now, because we have 10 times as many ICU beds as we have in the UK, we tend to have patients in that box. Not a lot. It tends to be quite regional, actually, and not very many. So what we've done is, I've neglected to tell you, is we pull the last 50 consecutive deaths. You just go down into records and you say, give me the last 50 consecutive deaths from a point backward. Okay, so it doesn't matter if it's from today backward or a month ago backward, 50 consecutive deaths, and you map them out. Now, over here, patient was admitted for palliative care and to a non-ICU unit. How many of you have those patients? Palliative care, non-ICU. Okay, so that's a certain percentage. And so why is that of interest to us? How many of you have so many hospital beds you just don't know what to do with it? You're thinking, geez, I'm going to have to figure out some way to use all these empty beds. Well, is the hospital the best place to die? Not at all. So having patients die in patients who come in for palliative care die in the hospital is not the best use of our resources or the best for the family, right? So thinking about how might we think about better care for these patients? Okay. So here's box 3. This is an interesting box. Admitted for palliative care here, no, okay. And admitted to the ICU. Well, these are all our trauma patients, right? These are patients who were admitted, didn't have non-palliative care. So you look at those, and there's going to be a pretty good percentage of patients there, and you want to be sure that they're still the appropriate patients coming into the ICU. The most interesting box, though, is box 4. Were not admitted to die and did on our general units. That's the biggest number of that 50. You'll find consistently in box 4. Okay. And so when we look at that box 4, here's about what we find. So we say comfort, non-comfort care. So essentially we're saying palliative and non-palliative. So we see almost, you see the range, 18 to 76%. But really, I have to say, 18 and 76 are really skewing that population. We see much more around 50% of patients who did not come in to die and did on non-critical units. So these are not our multi-trauma patients. These are not our multi-system organ failure patients, because they would be in ICU. So why are these patients dying? They were not admitted to die, and they did. And you can learn a lot from this 50 case note review. Some places do this quarterly. They're looking for shifts. And now everyone's going to die, right? You picked the last 50 deaths, so they're going to be dispersed somewhere. The question is why. So when we look at this carefully, what we find is we analyze box 3 and 4, and what we find most often is we see that the patient had things like poor communication, poor handoffs, and failure to rescue. What we're hoping for usually is that we find 1 or 2 big diagnostic groups. Wouldn't that be easy? Oh, I see we have a problem with community-acquired pneumonia. Oh, I see we have a problem with, heart disease. It's not that. It's not that. It's much more ubiquitous. It's much more has many more causations. And what we find really is the biggest issue for us is handovers. So what do we do? What does this accomplish? Well, it helps us say, yeah, all right, there are patients who are dying. We know that. But sometimes we don't understand why. It does help us look at that whole multifactorial reason of why patients are dying. So when I ask people, what are you working on in safety in your organizations? And they'll often say, and they should, by the way, oh, we're working on acute kidney failure, we're working on sepsis, all these things we're working on, and they're all excellent project-based work. But the cross-cutting themes that we continue to see patients die from are failure to recognize, failure to respond, and failure to communicate and do correct handover. So if those are not in your armamentarium and you're not working on those seriously, you are not going to beat down that box 4. Even if you take on all of those other challenges. Because people will say, well, yes, but we're working on sepsis. Well, how did that, so if we're talking about in-hospital sepsis, how did that patient become septic? If they came in septic, where would they be? They'd be in the ICU. They didn't come in septic. Sepsis was something that developed. It was our failure to recognize early signs of sepsis, or else they wouldn't have developed sepsis, severe sepsis, and died. Correct? So if you follow those things back, you often come back to the same problems of failure to communicate, failure of handovers, and failure to recognize and respond. So, and I'm not advocating for rapid response teams, although I think they can work beautifully. So can other things. Here's the point. I don't care what you use. I don't care if you hire monkeys. Here's the question I'm going to ask you. When you recognize that somebody is failing, will somebody come within 20 minutes consistently, not once in a while, consistently, and do the right thing? So people will say, well, we send our junior doctor. Okay. Are they prepared to do the right thing? Do they have all the tools they need to make the right decisions when they get there? Or are they going to now dither, waste more time, and then we're going to call the consultant or the senior registrar? So I don't care who you send. But somebody has got to recognize and respond to these patients routinely. And you can measure that very simply. So we think about this as a 3-stage process. The first stage is, three levels of reliability. The first is, can you reliably document the patient status? And that means the nursing staff, medical staff are reliably documenting the patient status so everybody understands it. If you can't do that reliably, don't worry about the second step. Right? So how many of you have found out when you started to do this that nurses are not taking temperatures anymore? Or pulse? Or respirations? Respirations is the biggest one. Why are respirations routinely left off? Because you can't plug them into a machine and take it. So we found if you see a patient who's, no matter what the rest of their vital signs say, their respirations are always 20, have a high degree of suspicion there, right? So we're not taking those. So it turns out actually respirations turn out to be fairly important. So we routinely and reliably measure. The second is we have a reliable system that when we call, they come. And the third is they reliably treat the problem in hand. And if you don't have a reliable system at every one of those, you do not have a system to rescue in patients or respond to patients. Okay, so I'm going to give you a couple little case studies that we found in our when we were looking at these charts. So here's one. Here's someone admitted, who was 84 years old, admitted at 7:14 with diarrhea, vomiting, and hypoglycemia, treated with fluids and oral glucose. At 8:20, the lab showed acute kidney injury, marked elevated urine or serum lactates. ABGs were high, indicating acidosis. No documentation of next steps or importance of findings. There's a big communication problem right there. No antibiotics were prescribed and no response to lab abnormalities. So complete failure to recognize we're in trouble and complete failure to respond. 6 hours later, the patient suffered a fatal cardiac arrest. Okay, so if you looked at the death certificate, you might say, oh, older lady comes in, admittedly quite ill, and died of a cardiac arrest. This is not the case that necessarily everybody will be all over thinking, wow, what did we do wrong here? It looks like, well, this probably was the end of life's journey. It was not. Okay, we just hastened that one right along. Okay. So here we find this woman, failure to recognize, case represents a failure to communicate, critical lab values, and it failed her at every turn. Okay, Roger. Is that me? Or Kathy, sorry.
You guys will know I'm not Roger, right? Okay. So following that along, we began to implement these things very broadly in the hospitals in the U.S., and some of you have used them in the U.K. and other countries. And we worked along and over a period of years trying to make our hospitals safer and safer and safer. And as Roger already said, we really weren't seeing huge gains in safety. Stuff was still happening. How were we going? So we had a large medical center in the U.S. call us at the IHI, and they said, we've done everything. We've done the 2x2s. We have the global trigger tool. And they listed some big consultants that they'd hired and they brought in, and they did everything, crucial conversations and handoff communications and SBARs, and they said stuff still happens. Help us figure this out. So one of the things we did, Roger and I, we contacted a fellow by the name of Stephen Spear. Any of you familiar with Stephen, his work? A couple of you. Okay, this is his book called The High Velocity Edge. I highly recommend it to you. His background, he's an engineer from MIT, but he works with Toyota Systems, who really developed high reliable systems. And what he started thinking about and taking us was an entirely different direction. And the direction began to look something like this. What we started to develop was a maturity model of the quality and safety within your system. And this is what it looks like. Level 0, we call that winging it, and we're now calling it the zombie organization. Just stuff happens, we don't know, we bump into each other, it's kind of chaos, there's problems daily in daily work. The next level up, there is some standard work, and we call that buffers. And buffers is like on a nursing unit or somewhere, you always have a little extra stuff around because you don't trust that you're going to get the pharmacy delivery on time, or you don't trust that you'll get enough linen, or you don't trust something. So people in roles standardize some of their own work, and it's usually by hoarding and kind of making things so we know stuff and we don't tell other people, and we gather our things around it. The next level up is an interesting one. The other thing down about the buffers is you see some standard work in this level, and in this level people themselves individually do some standard work. So they either do buffers or they have their own standard work for their role in their job. So in the U.S. we have what we call charge nurses, and they run individual units. So I used to be a staffing director, so I had all the units, wanted to know what was going to go well or not. When I looked at which charge nurse was on, I knew if I was going to have an okay evening on that unit or night. But it was because I knew that person, I didn't even know all this theory, but I knew that person had a lot of standard work and knew how to manage that unit. The next level up, we call it spectator. And there's two levels of spectator. It's spectator times 1. So that's when you go into an area or a department and they say, are you doing any quality improvement here? Oh yeah. Those people came in and we did the Kaizens and we did the spaghetti diagrams and we did these projects and we put things on the wall and we did that, and now we do it this way. And we said, oh, great. Well, now what are you doing? Nothing. We're just doing it this way. Because the people came in and we watched what they did and they told us, and now we do it this way. Spectator times 3 is the next level up. You start to stabilize your processes, but what happens is you do the same problems over and over again. Have you fixed the same problem in your organization every couple years? You kind of go after it again because it slipped away from you. You thought you had it fixed. That's spectator times 3. Again, it's somebody outside. It's not owned by the individual unit. It's not a standard process for holding the new work in place. The next one is systems began to change organically, and they began to create value. This is when the local unit begins to take charge of their work in some way, and the leaders are leading them along in doing that. That could be from the CEO all the way down to the manager of the unit, beginning to think about working on individual projects within that unit. And they begin to do PDSA cycles continuously on the unit. They don't get permission. They don't wait for the top-down project to reach them. They start to do individual work. The top one is really when the leaders of the unit are actually actively engaged in leading change. The senior leaders then becomes ones that sit back and start to listen to the changes that the units are seeing at the local level. And what this begins to do is mature an organization in their level of improvement. And this is all sort of how we've organized it from the models that Steve has developed. On the right-hand side, you see what the characteristics are of high reliable organizations. And I think you'll find them in Chapter 4 or 5 in the book. They have system operations. They have a way of problem solving. They share the knowledge, and then engaged leadership shares the knowledge across. Interesting thing is you can turn it this way. They see the problem. They solve the problem at the unit level, at the front line. They share their learning laterally. They tell the next shift. They tell the other unit. They tell somebody else. And leaders lead not by knowing all the answers, but by developing the problem-solving skills at the frontline staff. And when we started working with this, we were working with a group of quality leaders, and they said, when I asked people, most people say their organization is about in here, they think. Some of them might say somewhere they're up in here, but nobody feels like they're in the top. And if you ask them about individual areas within their units, they'll say they're all over the place. Boy, I got some down here, and I got some up there, and I got some that are doing it really well. And the big question was, can you adopt this? And can you jump a level or 2 or 3 or 4? And how do you do that? And what are the skills you need to help staff jump from some standard work to where they're actually managing things on the unit? I'm going to turn it to Roger in a minute. I want to say one last thing, is when you read Steve's work and you think about the Toyota model and you think about the work that they did, it was really developed during the Industrial Revolution when they were building factories. And at the factory level, the factory floor was actually run by largely immigrants who had very little education. They didn't know how to do Lean. They didn't know how to do Six Sigma. They didn't have a lot of this. Some of them didn't even speak the same languages, and some of them didn't even speak English. So they had to have safe, reliable systems that they could work together and make the products that they were trying to make in that context. So one of the things we're going to talk about is how do you begin to develop this on an individual nursing unit. Thanks.
So, ladies and gentlemen, you've gotten some context, but let's put it now into the big picture. We're suggesting that a safe organization needs to think about 3 calibrations. The first calibration has to do with large projects, necessary but not sufficient to create a safe organization. You can compare yourself to other organizations. Everything you do is good. It's primarily a top-down approach. The second calibration, that having to do with mortality, is a great calibration because it looks at system issues, the complex systems within an organization. Even those two, when done well in an organization, does not significantly improve the organization's safety. Now, why would I say that? We know from the global trigger tool that the average number of adverse events in an organization for every 10,000 admissions is 4,000 adverse events. This has been played out in country after country. The bottom line becomes those projects in the first calibration, the mortality and the work you do in the second calibration, barely touch the 4,000 adverse events we're seeing for every 10,000 admissions. So the question becomes, where do we go? What is our hypothesis? How can we teach you, or how can we learn what needs to be done to make our organization safer? This is where we turn to industry. Steve Spear works in industry. He is an expert in the Toyota production system. Many of you may have read about the Toyota production system, but one of the things that intrigues me is they talk about many thousands of changes that occur every year to the assembly line at Toyota. And then they go on to say that 99% of those changes are bottom up, not top down. So let's compare the first two calibrations we talked to you about. That's the brunt of the safety work that's being done in healthcare at this time. It's all top down. Is there some reason to believe, or is there some reason to hypothesize that perhaps when looking at industry, that the third calibration we're talking about, the calibration where the units take charge, where the units find the defects, will have a huge impact on safety? And that's our hypothesis, and that's how we're going to spend the rest of the afternoon in our session talking about that. And it has to do with a methodology that we have uploaded or downloaded onto the site. It's a paper that describes this methodology in detail, which hopefully we won't have enough time to go through today in detail for you, but you'll get enough of the concept and interest in it that you would read this paper. What we had the experience to do in a leading institution in the United States, when they asked us, why are we not getting any safer and yet we're doing the first two calibrations, we didn't have an answer. So we went to their organization and we designed a methodology that tracks along what industry is doing, what Steve Spear's work describes in the book and the methodology that Kathy had walked through with you. We have now designed what we call a front-line defect project model. And I will walk through this very briefly with you. We design a conversation that we have with the front line. The conversation has very strict rules, using certain types of questions and being very non-confrontational. These conversations surface frontline defects, both clinical and non-clinical defects. The average conversation takes approximately 60 to 90 minutes. It's led by a facilitator. This facilitator knows which questions to ask. We call them anchoring questions. These anchoring questions are like this. Do you have good days and bad days? Describe for me your last bad day. These kind of non-confrontational questions, if you give them to the front line in a 60 to 90 minute conversation, will easily surface somewhere around 15 to 20 defects that the front line is dealing with every single day, but they don't recognize that they're issues related to safety at all. What they say is, this is what I have to do to get through my work on a daily basis. They do not consider it anything beyond that. And yet, the defects are obvious when we do the conversations. So we surface those defects, identify them very succinctly, collect minimal data to make sure there's enough volume with this defect, suggest strategies, and then have the front line actually solve the problem. These are the rules. You solve the problem using 2 people. The problem needs to be solved in under 30 days. It requires only the data you can collect with a piece of paper and pencil on the front line, and it requires no training beforehand. We have now taken completely and turned upside down the approach from the top down versus the bottom up that we are now hypothesizing is the next calibration. Let me share the framework with you, and this is discussed in detail in the paper. First, we surface the defects by a very specific methodology using anchoring questions, and the result of that is front-line engagement. You will not believe the degree of front-line engagement you get with this because it's a purely non-confrontational conversation. That takes 90 minutes. We then require leadership to scope this project, to make sure that this is a project that can be done at a unit level by a team of 2 people without having meetings, and that this project will not influence some other part of the organization in an untoward way. So that's the scoping that occurs, but what happens there importantly is that leadership gets engaged in this work. They align the work with strategic issues within their department or area. You gauge the capacity of that unit to do this work, and you articulate any implications that might affect other parts of the hospital. That happens within 2 days of the conversation.
It doesn't take 2 days.
It doesn't take 2 days. It happens within 2 days of the conversation. We then have the next step, which is validation. Here, the front line actually goes out and counts the number of times this defect occurs. We don't want to work on a defect that doesn't occur commonly. So they actually count the number of defects. And the interesting thing is, they will then actually go ahead and look at one of these occurrences and try to find out why this occurrence happens. What is it that's happening in the milieu that's causing this defect to be common enough that it's interfering in your work on a daily basis? So we then engage the front line again. This data collection takes 1 day. If it's happening commonly, you should be able to see it on a daily basis. So we want to take 1 day to do that. We then select the specific work that we're going to do. What is the specific change we're going to make with this organization? We define boundaries. We'll tell them what some simple measures are that they can actually measure the project. And here's where you engage the person who's actually going to do the test. Remember, 2 people work on this, not a team. There are no team meetings. So you engage that tester, and oftentimes the person back here who told us about the defect, almost 100% of the time that person becomes the tester. So that's how you really engage the front line. And then you finish the project in under 30 days. Lest you think this is a pipe dream, let's share some of the information with you. This is at Mayo Clinic. I've been doing it there now for a little over a year, so some of these examples are a little old, but they'll demonstrate what we mean. We've had 3 one-hour conversations with the front line in this particular unit up to that time. This is a couple of months ago, almost a year ago. Participants were the hospitalists, the social worker, the dietitian, nurses, discharge planners, and pharmacists. You want to get a broad section of the front line so that as you surface the defects, you get defects from across the front line.
Roger, what's a hospitalist?
I'm sorry? A hospitalist is a physician that just takes care of the patients in the hospital, much like you have in the UK. During these 3 conversations, 39 defects were surfaced. These are things that leadership had no idea about whatsoever. Now I'm going to tell you about one of the things that was surfaced, and I'll show you exactly how simple and how minimal it was. At Mayo Clinic, they have something called the vitals machine, in which you put your arm into it and it takes your vital signs. We asked the roomers, why is it, so we asked them, what makes for a bad day? And they said, when we have a lot of obese people. This was a surprise to us. Why? Because the vitals machine doesn't work with a very obese person. Now they have to run around and find a manual blood pressure cuff. This is a minor defect. But can you imagine how much this must interfere with the flow of the clinic during a given day if you have a lot of obese people? No one knew about this. This was a defect surfaced by people who room patients. So these are the types of defects that are being surfaced. Of these 39, 46% of these moved on to improvement projects that were scoped by leadership and then went on to be fixed. And of those, 15 of 18, or 83%, were resolved within 1 month. This is the power of this kind of approach. So, Kathy's going to give us an example at Cedars-Sinai where we actually developed and tested the methodology.
I'm actually going to give you a couple examples, but Cedars-Sinai was the organization that came to us. They're a large academic medical center in Los Angeles, have all the resources you could possibly imagine, have done all of the things for safety that are recommended, have EMARs, have electronics, have consultants, and they said, things are still happening here, could you come and help us? So when we did, we went on to the units, and as Roger said, we began asking questions. Within about 3 minutes, these defects started to surface from the staff. And I'll give you an example. We visited a radiology treatment area, and in 1 week of tracking, they found 33 defects identified. And they began to sort them and work on them. The thing that Roger said is you need to do a little bit of data collection, because if somebody says it happens, and it happens only once every 3 months, and maybe it's aggravating, you really want to get at the things that get to people every single day and disrupt them. A couple of the things were simples, that patients come to them without any pre-medication orders, and they have to scramble around and get them. Patients with hip replacements, they need femur head XRT, and they're always calling down right before the patient's to be discharged, and it becomes a real disruptive thing for the area to be able to do this procedure. Guess when they know that the patient is going to need that radiology treatment post-surgery? When the doctor sees the physician in the office to schedule the surgery. So if they would know at that time, they can schedule it right in, and the whole thing becomes a non-disrupting interrupter to this unit. Patient arrives without the results, their scans are delayed. They also talked about patients with having radiology treatments for cancer, and they come in and they're red and kind of blistered, and it's very normal, but we've never told them it's normal, so the patients think something's wrong, and they come in and they have to drop everything and spend their time working that out. What they did was they took each one of these separately and individually and put systems in place to eliminate the defects. So they now schedule the XRT treatment at the same time the OR is scheduled. It's built right into the schedule. They have training modules that nurses actually go over with the patients that are going to have radiation therapy. Say in about 2 weeks, this is what you'll expect, this is what you do about it. I wanted to give you a couple more because I've been working with some other areas and units, and these literally just arrived at my desk last week. There was one team that was working in an emergency room, and what they found that during the day, they worked with the techs and the unit secretaries. They were interrupted an average of 30 times during an 8-hour shift by call lights for patients. And what they found was just 3 things. Help me to the bathroom. I need pain medications. What's the plan? Where's my tests? So they put in some systems of hourly rounding where they would actually go in and check on those things. They were able to cut those in half within 1 week, and they were able to cut them down to only about 2 interruptions per shift within a 3-week period, as Roger said, in that 30 days. So what you need to think about is, what is this doing to your staff's day when there's all these kinds of things happening, and how can they take steps to begin to solve this. There was another one with 23 physicians in a busy cardiology clinic, and people were always asking the coordinators where the patients are. Where's the patient? Where's the patient? Where's the patient? To the total of in an 8-hour shift, they were asked 25 times, where's the patient? 3 times in every hour, somebody's running around looking for a patient. So they put some systems in place. It turned out the EMR, which nobody was using, had a tracking system in it. So as they started to do that, they were able to take those down to about 2 times a day that happens that somebody can't locate the patient on their own. The most interesting thing about all of these is they are very straightforward problems that can be solved pretty much at a unit level with some little bit of system thinking. But when we left Cedars, they said to us, well, you're just telling us about these little problems. You don't have the big magic answer. And what we were able to say to them is, we don't know what your next event will be, and we don't know what your next event will be. But we know that the seeds of that event are being sown in your organization every day. And they're being sown by things staff describe as normal. They don't see this as anything wrong. It happens all the time. This is what we do. This is how my day goes. And what we really want to try to do is help them create small islands of stability so that they can take charge of their unit and begin to eliminate these defects completely and get them out of their way and get about the business of work. One of the things that we realized is that they also told these stories about these things that happen every day that create emergent situations, and someone heroically rushes in and solves the problem. And that was what they thought was a good thing to do. They didn't even really see that they could work together to make sure the problem never occurs again. And it was pretty straightforward to be able to do that. So I'll turn it back to Carol to end it up for us.
So one of the things that Roger and I worked on years ago was idealized design of the intensive care unit, and that's where bundles and a number of things came out of that work. But another piece of work came out of there that fit this, and we didn't know what to call it at the time. And that is, how many of you get called again and again to ask for how the patient's doing? Family members call and call and call. And it drove this intensive care staff crazy. They wanted to give that information. They always had to ask, Are you the contact person? Are you the person who has permission that I have permission to speak to? So what they decided to do was they tried, and they could do this on a small test, is they set up a mailbox for that patient, and every day they went in 3 times a day and updated how the patient was doing. Now, if Andrew is the contact on record, you can give out that phone box number to anyone you want. And anybody you want can call in and find out how their loved one is doing. You're the gatekeeper for that. And they stopped calling the unit. Now, what's that got to do with safety? Nurses are running around disrupted all the time. Junior doctors were disrupted all the time. So these are seemingly small things, but that add up to big gains. It's better for the families. They have routinized, they know when to call. And when people know what to expect, it turns out they'll pretty much be good with that. If they know it's going to be up to 3 times a day, they'll wait. How many of you are familiar with behaviorism? Skinner's work? The most difficult behavior to extinguish is that which is rewarded on a variable ratio schedule. And that is, I cannot predict from one moment to the next, or one day to the next, when I'm going to get the information I need. So I'm going to keep calling. Because today, it was at 8 and noon and 4. Tomorrow, it turns out it's at 7 and 2. So I'm going to play this game with you forever because you've taught me I have to. There is no expectation. So honestly, we create these same behaviors in ourselves all the time. So 3 things three ideas we've given you today, I hope. The first is, and they're not a priori. We're not suggesting to you that don't work on large systems improvements. Those are important. We're not suggesting to you don't look at deaths as a source of information. Those are important. It's also true that at the end of the day, we're finding that even with all of those very important projects that are helping our patients, things slip through all the time, and they surprise the heck out of us. And we think, how could that have happened? But they happen routinely. So one of the questions I like to ask staff is, tell me about the last time you didn't know how to take care of a patient. That you had a patient you didn't know how to take care of. And it's amazing the stuff they tell you. Scare the heck out of you. You have to learn to modulate your breathing while they're telling you these things. But these are things they deal with. They're just used to having patients they don't know how to take care of because they got off-service patients every day. And we have just accepted this as normal now. So how are we going to get past this? And this is not going to necessarily be, would I like it to be a big flow thing where every patient gets to the right bed every time? Yes, I do, but Roger and I worked on flow for years, and I would say it is still a huge problem. So how do we get to those little defects that bother people every day, but that roll up to help us get past the problems that are creating so small defects for us all the time? So it's really all of those things that might make us safe.
Carol, thank you very much. Carol, thank you very much. Come on up here, guys. Come on up and talk here. That was absolutely wonderful. Thank you.
No, you too.
Come on up, Roger and Kathy, because it's much easier for the audience to see you up here. Look, I really love that original slide that you preceded at the end, which said, can we do the big things? Well, I asked myself, can I do the big things as an individual? And the answer is no. Can I look at the mortality data? Well, yeah, I guess I can. But can I do the small things? And the answer is, yes, I can. And it reminded me of that, Booker Prize-winning novel, The God of Small Things.
Oh, I love that.
Can I be the God of small things? Can you be the God of small things? I think the answer is yes. And I think that really is the message that you brought to us today. That was fantastic. Now, let's see what we have on the Twitter feed. Hannah, how are we doing?
Okay, we've got 3 questions, and they're all on the Frontline Defect-driven project. So the first one is, how many interviews do you need to surface the defects?
I didn't hear the question.
How many interviews do you need to surface the defects?
Yeah.
Interviews.
To surface.
You start with 1.
I speak UK-ish.
Yeah. You start with 1. This is a 60 to 90 minute conversation. Download the paper that we have. It will describe how to set this conversation up and how to ask the right questions. The questions aren't, tell us about things that are unsafe on your unit. They don't understand that these are safety issues. You ask them, what made for a bad day? What makes it difficult to take care of your diabetics? What makes it difficult to take care of patients with congestive heart failure? Those are the kind of anchoring questions, because once you anchor the patient to a concept, you can then explore the defect very, very easily.
How many people do you need to talk to?
We usually like to have about 8 to 10 people in the room.
Why not 2 or 3?
It's too small. You want to get a broad section.
Can I bring Carol in here? Because one of the things, it's easy in the American context to think it like this, but Carol, you have a lot of experience in the UK. Who's going to ask those questions in the UK? Or I say, we have a very European audience as well. Who's going to ask those questions?
Well, you're going to have to decide who can be that person. So this isn't something that probably you're going to have a staff member step up to. But who right now is leading leading that work in your organization? I would say it certainly could be someone on the unit who learns how to do this well. Somebody who has good relationships. It might be a quality manager. It might be any resource person who has it could honestly be, let's say you've got a physiotherapist and they're interested in improving their work with you. They might say, what about the work that when I come to do this work, what are the sort of things that I could do to help you or that haven't gone well when I'm here?
We have found by experience that it takes almost no skill to lead this conversation if you follow the directions of the simple anchoring questions.
The key is the question, because you don't ask the question, what's unsafe? Then they start telling you about the floors and, what aggravates you. They start telling you about the other unit and all those people over there and all these projects they have to do. So you have to ask the question about the patients on this unit. Tell me about a time you didn't have everything you needed. Tell me about a time when a patient was delayed for some reason. When was the last time? You just ask them those kinds of questions, and then things come out pretty
I'm
quickly.
assuming from doing some of this myself and hearing from you two as well, that you don't want questions that ask them to disclose too much personally.
That's right.
You don't want to say, tell me the last time you did a lousy job taking care of someone. Who was that and where was that? Probably not going to be very helpful. But if you ask them, think of a time, they really don't have to disclose boy, that's something I'm really anxious about or afraid of or ashamed of.
Yeah, the other thing is you need a very narrow, a narrow gradient in terms of your hierarchy, as David Evans told us last night. We really, everyone needs to be enabled to ask those questions. Hannah, you have another question on Twitter.
Does the model fit alongside the clinical microsystems model?
Absolutely.
Yeah.
This is the microsystem approach, but the difference is this. All of us have been exposed to the microsystem and the idea of bottom-up, but the methodology is actually missing. This is the methodology for getting the microsystem involved in a very simple, straightforward way.
Okay, now let's see if we have any questions from the audience. Any questions from the audience? We have a couple of questions at the back. Hannah, are you going to... Yeah, okay. Not alone have we got, just to embarrass Hannah, not alone have we got the A-team on the podium, but all of you who've been doing Twitter, none of these things happen by accident. Somebody runs the Twitter. And today we don't have an info DJ, we have the queen of info DJs, because it is Hannah has been coordinating the whole program of Twitter. So thank you very much indeed,
Thanks,
Hannah.
Info DJ. I couldn't remember the word.
Now, where's the microphone? Great stuff.
Andrew.
Hi, Andrew Hallahan from Brisbane, Australia. Thank you, that was fabulous. My question really is to ask you to reflect on the power of the local microsystem leadership. I mean, to me this model is terrific, but it's probably fairly dependent on the skill of the immediate local leader. What would you like to say about that and how you support them?
What you're thinking?
Actually, the experience has been that the local leader mostly has to give permission for this to happen.
Just get out of the way.
Get out of the way, right. And that the leadership involvement primarily is in scoping the project and making sure that this does not turn into a team meeting. Those are very important characteristics, because as soon as it gets too big, it becomes the traditional team approach to improvement. Keeping it at a two-person project, making sure that the data is only collected with pencil and paper, and then collecting and making sure it gets done in 30 days. That should be the leadership responsibility. Otherwise, get out of the way.
And I will say the leader's role is in something creating the context. So what we've found on most of the units that we visited at Cedars was even when they told us, well, gee, we had this problem and this problem and this problem. Well, what do you do in your day to solve your problems? Nothing. We just try to get out of here as fast as we can. And then we said to someone, when do you report it? Oh, well, we'd take that to the safety committee. When's that meet? Oh, quarterly. I think they just met last month. And you could,
it's the month beginning with during a full moon.
And you could see the leaders of the organization, the color draining out of their faces as they were seeing all these defects being surfaced and then nothing done about them. So at the local level, the leader can say, at noon every day, we're going to take 10 minutes. We're going to get 4 of us in the conference room. We're going to see what's gone wrong that day, and we're going to, work on our defect problem. They can create the context for beginning to do that, and we'll keep a flip chart here, and we'll line up the next problems that we think we might want to work on.
In organizations that have taken this to the next level, what they do is they usually have 4 conversations a year each quarter. The expectation is that at each conversation, they're going to pull out 4 to 6 projects that they've scoped, and the expectation is that they will have, at the end of the year, 80% of those projects will be completed within 1 month. You saw the data up there from Mayo Clinic. That's where leadership comes in, setting expectations for getting this done within a month and measuring that.
And I suggest a tracking system.
Yes.
Yeah.
Just the most rudimentary.
Super. Let's see if we can get another question there. Thank you very much, Hannah. Sorry, it's a bit of a trek to the back there. I think we'll probably have to say this is our final question.
Yep, we see people.
Thank you for this.
We can talk to you offline too. Yeah.
Thank you for this lovely presentation. I'm a huge fan of bottom-up approach. But I have a question. I work in a mental health care hospital, and we have a huge problem by implementing an electronic medical report. And isn't it a risk that the nurses or healthcare professionals will complain about those complex issues which they cannot change in 30 days? And isn't it a risk that they will get frustrated about this approach?
Well, those issues always come up in the discussion.
You just scope it.
That's why the scoping step is so important. And when the front line sees what sort of projects that we're allowing them to handle, the conversations get better and better in terms of these large complex issues. Some of these large complex issues may end up becoming large top-down projects. Leadership can decide that. But at this point, we're looking for the small defects that can be handled within the requirements of this model.
And I'll add one quick thing to that there's this kind of learned helplessness that takes over. And all these things happen all day, and we salvage them, and we're interrupted, and we just get out of here, and we come back the next day and do it again. When the units themselves and the local microsystems can start solving their own problems, the big problem of the EMAR doesn't seem so disruptive to them because they've created that island of stability in their own department. Then that one goes up somewhere else. If you let them just complain about something they can't solve all day long, you've lost the energy to begin to work on their local problems.
And we'll give the very final word to Carol.
Oh, thank you. Travel safely.
Thank you.